Thanks for that introduction and for inviting me to speak this weekend. It's a big honor, and it's actually pretty daunting for me because I'm not a pain specialist like many of you are. But I hope that I can share a few things that I try to do when I see people having pain in the urgent care. So first of all, let me share my screen. Make sure that works okay. Give me 3 seconds here. A lot of you guys probably know what an emergency department looks like, maybe from your own experiences or those friends or family members, or at the very least from the occasional TV show. But what's an urgent care? Urgent care is a pretty non-specific title that I've seen on little clinics that are in walk-in kind of places in strip malls. This one was in Hawaii when I was there several years ago. But ours is not like that. Where I work, the place I work, it's a little bit bigger. It's a 24-hour urgent care center in the heart of a city of over 1 million people. The only major city, by the way, Calgary is the only major city in Canada that doesn't have a downtown hospital, because we blew it up in 1998 during some really big cuts to the healthcare system in Alberta. So that was the largest hospital in North America to ever shut down. And that left Calgary with a 24-hour urgent care center in the downtown core instead of a hospital. And we're pretty proud of our urgent care. We've grown into a facility that accepts ambulances 24 hours a day, 7 days a week. Now, not big traumas that obviously need to go to a full emergency room, like gunshots or open fractures or obvious heart attacks or strokes. But we also see those sorts of things walk in or get dropped off by friends who basically shove them out of the car or the truck and just leave them at our doorstep instead of calling 911. So we're really not designed to see full-on trauma, but we are designed to see non-life-threatening conditions, painful conditions, like broken bones and undifferentiated abdominal pain or chest pain, dislocated shoulders, moderate trauma, like cut fingers from restaurant kitchens or roofing nails through hands, things like that. But we do occasionally get big things walking in, and we are set up with a trauma room so that we can deal with that, and whatever comes in we deal with, and then ship off if we need to. And we work downtown, so steps away from the safe consumption site for people with opioid or more commonly polysubstance use disorders, and in the same building as the opioid dependency clinic. All the challenges that come with our environment aren't unique to the Schumer. I mean, walk into any hospital emergency department or similar standalone emergency department or urgent care center, and you'll see a similar environment with similar challenges to treating pain. In fact, the emergency room and the urgent care center, it's not a great environment to be in pain, unfortunately. I mean, we're almost always busy. These days, we're often short-staffed. We're more stressed than ever, thanks to COVID, as are many of our patients, of course. There's almost never enough time to fully address people's problems in a comprehensive way, and pain treatment suffers. Now, everyone's pain is different, so a cookie cutter approach to treating pain can't always work. And I'm sure that a lot of you know that, much better than I know, that it's not just about giving a patient more and more pain medications. We need to think about both medications and non-pharmacologic treatments for pain. So let me tell you about a couple of patients that I've seen in the urgent care in the last little while. And about their pain and how we dealt with it, hopefully effectively. Honestly, not always, but here we go. So the first patient that I can think of, it was an energetic lady in her 60s who was visiting family over the summer, and she had an unfortunate incident in her daughter's kitchen. Her daughter's dog actually bowled her over, and she landed hard. And she ended up breaking her arm, kind of like this fracture. So this isn't her actual x-ray, but it's one that's very similar to hers. And you can see on the x-ray that there's this little jagged piece of bone here. This whole piece of bone is broken off of the bigger humerus, which isn't very funny. So these types of broken bones, they actually heal really well without surgery most of the time, but they hurt a lot. This fracture moves around. It's pretty unpleasant. So her daughter, took her in to one of the busy emergency departments close to their house. And she was taken care of, and she was x-rayed. She was told that she needed to wear a sling, and to arrange a doctor back in Ontario to see her when she went back in a couple of weeks. And she was given a prescription for 2 milligrams of hydromorphone pills for the pain that goes along with a fracture like this. And she was sent home. And then she came to the 𝐒𝐂𝐑𝐈𝐁𝐄 to the urgent care where I saw her a few days later. And she was, as the nurses told me, pretty angry and demanding more pain meds. So the triage nurse had already given her some ibuprofen when she checked in, and she took it reluctantly. And apparently she muttered something about needing something stronger. Now, to give you a little bit more context about the 𝐒𝐂𝐑𝐈𝐁𝐄, we try really hard not to prescribe opioids, although we will use them to treat acute pain, obviously, while people are at the center. But this idea of not prescribing them to go has been a longstanding policy. Back in 1998, when the Bow Valley was blown up and closed, the 8th and 8th Health Center opened, and the no narcotics health policy was actually written on the front door. And then in 2008, 8th and 8th Urgent Care became the Sheldon Schumer Urgent Care. So that's the background. Bottom line, I was a little bit leery of a possible confrontation or disagreement when I went in to see her. So I took a deep breath, I knocked on the door, I introduced myself, I sat down, I gave her an ice pack, and I asked her to tell me her story. And I listened. And she told me that her pain was out of control, that she couldn't sleep, that she couldn't imagine flying back home in this kind of pain, and she wanted something more for her pain. But it turns out she didn't actually want more hydromorphone. She didn't like it. It made her feel woozy. It made her feel lightheaded during the day. It did allow her to get a little bit of sleep at night, but she was very afraid of becoming addicted to it or dependent on it. She was concerned that all the pain that she was having every time she moved meant that she was doing some irreparable damage to her shoulder. She was pretty distressed that the sling that she was given at the emergency department wasn't doing what it was supposed to be doing. She had, wasn't sure if she was wearing it wrong or something, because she still had a lot of pain. So she was alarmed that her broken bone was going to take, upwards of 2 months to heal, and yet she had only been given, like a few dozen pills, about half of which she had already used before coming to see me. So I listened to her story and her concerns about the fracture and the pain, and I examined her shoulder carefully to make sure nothing truly bad was going on. And I told her about other things that she could do. I asked her if she knew about other things that she could do to control her pain. She hadn't been told, or at least she didn't remember being told, that she could or should take plain old Tylenol and Advil in addition to the hydromorphone, or instead of the hydromorphone. She hadn't been told that putting an ice pack on her shoulder could help both the pain and swelling. She hadn't thought to ask at the time about how to sleep. And she found herself actually stuck in bed the first night, laying flat on her back, because she couldn't get up with the pain in her shoulder and the immobility caused by her fracture. So we spent time talking about the use of over-the-counter meds, about ice and eventually heat, about using pillows to prop up her arm, and maybe sleeping in a different posture, and about how the sling was supposed to help by basically hanging her arm down rather than immobilizing her shoulder, and about how most of the pain would actually fade in the first couple of weeks, long before the bone was fully healed. So through that whole process, she visibly relaxed. She told me that her pain was better, under better control at the end of the visit than it had been all week. I think that most of that pain relief was due to the ibuprofen, probably, that she got from the triage nurse. Part of it was maybe from the ice pack that I gave her. But I think a lot of her pain relief came from her overall relief, that she had had her concerns listened to, that, you know, now she knew that there were other things that she could do to control her pain in the days to come, and that we didn't expect her pain to last as long as it would take for the bone to heal. So thinking of this lady and the lessons that she taught me, ask people about their pain and their pain experience, and try to understand what they're going through and what they're expecting and what they fear, and really listen to you know, what they have to say. Be curious, not judgmental. That can help to align our expectations and goals with theirs. Treat pain early. I mean, partly because it's the right thing to do for the people that we're caring for, partly because it helps to gain their trust, showing them that we care about them and their pain enough to do something about it up front. And because pain is a powerful distraction. I mean, I wonder how much of the things that I was telling her were actually told to her in the emergency department when she was initially seen. But because she was in pain, and, you know, probably a little bit of emotional distress, at least at that time, it's hard for her to remember anything when people were telling her stuff. So the other thing is write things down. Write things down for people. There's plenty of research showing that people remember very little of what their healthcare providers tell them. And, you know, whether that's with standard handouts or personalized notes that you give to people, give them something that they and their caregivers can refer to later. I think that, you know, in the rush of our normal days, we sometimes forget that even though we see things like broken bones and burns and sprained ankles and stuff all the time, it's often the first time that the patient is experiencing that. And they don't know what to expect. They've never had a burn or a broken ankle or a broken shoulder or anything before. So that's one patient. Another one, this is a quick one. There's a rough looking guy. He was swearing, he was muttering under his breath as he got brought back to the exam room by the nurse. He had a toothache, and his chart said that he hadn't had any pain meds all day and that he had no allergies. So he had actually refused Tylenol from the triage nurse. So I grabbed some ibuprofen and a glass of water, knocked on the door, walked in the room, and he was sitting in the chair and he was holding his head in his hands and he was just kind of quietly sobbing. It took a minute to convince him to take some ibuprofen. I mean, I told him, look, it can't hurt, and I'm going to be doing other things for your pain as well, not just the ibuprofen. So he took it, and then we talked. And he was angry. He was angry that he had had this pain for so long. He was angry that he was in this situation. He was angry that he had broken his tooth a couple of weeks ago and just kept working because that's what he did. He was trying to avoid hard drugs. He was trying to avoid, you know, homeless shelters and stuff because he was homeless. But after a few days, he just couldn't function anymore. So he went to a walk-in clinic. And at the walk-in clinic, he was told by the doctor there, apparently, that the doctor apparently said, I don't know why you're here. I'm not a dentist. And he was given a prescription for some Tylenol 3s. And he said, the doc didn't even look in my mouth. So he used the last of his money to buy some Tylenol 3s, which he used for a while, but then the pain got worse. And when I examined him, it turns out he didn't just have a broken tooth, he also had an infection. So I told him, look, we're going to need to do something about this. And he started to get riled up. I think he thought that I was going to send him back to another dentist. But I told him, no, we're going to take care of at least part of this today. You will definitely need a dentist, but we'll get to that in a second. I told him that, you know, I could drain that little bit of an abscess and I could freeze his tooth, and that could give him, you know, probably several hours of really good pain control. He did not like that idea. He did not like needles. Which is surprisingly common in big strapping guys. I don't know why, but if anyone out there has some extra research funding, that might be a fascinating topic of study. Anyway, he eventually agreed to try the freezing, and it went great. I mean, you know, not really great. Everybody hates getting needles in their mouth when they're already sore, but, you know, other than writhing a bit in the chair, he didn't bite me. He didn't, you know, spit on me. And 10 minutes later, when I went back in to check him after draining his abscess and freezing his tooth, he was asleep. He was asleep in the chair. So I let him sleep. And in the meantime, I called the dentist on the phone. We have a low-cost dental clinic at the Sheldon Schumer. I arranged for him to be seen the next day. I got him a prescription for some antibiotics. I gave him the number and the prescription, the number for emergency social services so that he could get the prescription filled. Gave him a prescription for some prescription strength ibuprofen in the meantime. And he did great. And he went to the dentist and he got his tooth pulled eventually and went well. So for this guy, a couple things. Think outside the box, your box, whether that's, your box of opioids or, your branch of practice or whatever. Diversify the tools that you've got and be creative to a point, with applying the tools to different circumstances and different problems. Healthcare has become really siloed in a lot of ways. Like, the walk-in clinic doctor saying, I'm not a dentist, go to a dentist. But you can ask for help from dentists and psychologists and physiotherapists and occupational therapists and orthotists and pain specialists and social workers and family docs and whoever. The goal isn't for you to fix the problem. The goal is to have the problem managed. A long time ago, one of my mentors taught me that when we're doing episodic care, there's a temptation to sometimes not address a problem because it's complicated. It's not a quick fix. You can always sort of just say, well, go see your family doc about it. Go see somebody else about it. But he told me to try to own the problem if I could. Sometimes that means coordinating care with others. Sometimes that means, trying to get somebody admitted to hospital or advocating for your patient in some way. You're probably not going to be the first person that your patient has turned to for help. If you are, fantastic. You might have an opportunity to make this sort of a one and done pain experience for this person. But if not, don't be discouraged, don't be defensive, knowing that you might not be able to solve this problem completely. But be helpful and try to take at least a step towards the solution. We all have a lot of stories like these and lots and lots of other stories where the situation wasn't resolved as well or as easily. There are a lot of challenges to treating people who are experiencing pain, especially in the chaotic and episodic world of urgent care and emergency medicine. And we can always reach for more pain meds, whether it's something for acetaminophen, ibuprofen, opioids, ketamine, whatever. But let's not forget the art of medicine and treating the patient as well as treating their pain. So these are my tips. As I said at the very beginning, I'm not a pain specialist, but I try not to see that as a flaw. I'm actually starting to think of myself more as a pain generalist. And I'm going to lean on the specialists out there, including all of you folks, the psychologists and social workers and pain doctors and all those folks that I mentioned earlier. So thanks. Thanks for helping me to be a pain generalist and for being pain specialists on your own.